Welcome everyone, and thank you for joining us for the second joint webinar between the Forensic and PICU Quality Networks. I'm very excited about this webinar because staff support and wellbeing is a particular area of interest for me and a focus for the project, particularly in the PICU project in the recent past. And I think now, as we see cases of COVID sort of starting to dwindle, I think it's a really important time to start making sure we protect staff at this particularly vulnerable stage. So I'm very pleased and grateful and delighted to have Professor Neil Greenberg and Dr. Tracy talking about staff support and moral injury, and also touching on their experiences of working in the Nightingale Hospital. So just to let you know, this session will be recorded and made available on our website in the next few days. And I really encourage everyone to use the question and answer function and the chat function, and we'll have dedicated time towards the end of the webinar to address as many as possible. So without further ado, I will pass you over to Neil Greenberg.
Thank you very much indeed for inviting me and Derek. Just to tell you how we're hoping this will run is that I am about to share my screen, which hopefully has worked. I'm going to do the first half of the presentation and Derek's going to do this second half. And we will make sure that we leave time at the end for questions. So please do send your questions in, as Kate said, because we do want to make this interactive. So first of all, sort of kicking off, it's worth saying that in terms of what's been happening over the last few months, there's been a different range of stressors that have probably affected people working in healthcare settings. There's obviously been trauma, and this can be both in a classical sense in terms of horrific stuff, and also about moral injury, which I'll mention in just a second. And unfortunately, as we know, people have died, and there certainly has been risk both to healthcare workers themselves in terms of being infected, and also potentially to their family. Many healthcare workers have found that the workload and shift pattern has been longer and more difficult than normal. Certainly, as Derek will tell you, our experience of working the Nightingale was that shifts there were 12 hours long, and people were on many shifts in a row each day. Home life has also been a challenge. There is this ever-present risk that you may end up taking some of your work home with you in the form of infection, which is not good for you and obviously not good for your family. But there's also the same sort of stresses that the rest of the population have had to deal with in terms of restricted lifestyles, potentially financial difficulties if you or your member of your family have lost work. And also, we know that relationships can be fractured, and certainly domestic violence generally, not saying just in healthcare workers, is on the up. And there's also this concept of what's called moral injury, which is something which potentially was first talked about in terms of the military. You can see here a range of different definitions for what moral injury is. But basically, it's a situation in which the circumstances that you find yourself in dramatically clash with your sense of what's morally right or wrong, your moral or ethical code. And what that means is that as a result of what's happening not fitting with what you believe, is it causes you intense distress. And this can come from acts of commission, so things that you or other people do that you really wish you hadn't. Omission, that means you didn't do something didn't happen. Or betrayal by a higher authority. And we'll come back to that just a little bit. And that's often being that your managers or the government or the health service didn't provide you with the support that you should have had. This comes from a Centre of Mental Health report which came out last month. This is looking at the potential impact of COVID-19 on the general population. And what this is trying to show is that over time, there will be a peak of mental health problems, probably as a result of the intense work, and that's been going on. But actually, as COVID begins to improve, and let's hope it continues to do so, the mental health need is likely to continue. And that's likely to come both from the direct effects of COVID, but also from things such as the financial downturn. And we know that that's linked with suicidality and depression and other bad things. And also because of a range of secondary difficulties, relationships, financial pressures, and other things that will go on, which are secondary to COVID. In terms of the general population, the predictions are, and I'm always careful to not believe predictions too much, that probably something like 500,000 more people will be experiencing mental health problems over the next few years because of the economic impact of COVID. And that's likely to lead to problems, particularly with depression. There's some communities who are higher at risk, people from BAME backgrounds, as we know, and also people who have poverty issues in the first place. There's complicated grief, and we know that unfortunately people who have lost loved ones in this current pandemic, many of them haven't been able to say goodbye in a way that they would want to, and it's unclear quite what impact that's going to have in the longer term. There's obviously those who have been in intensive care, and there's good evidence that being admitted to intensive care dramatically increases your risk to get mental health conditions such as PTSD. We don't know obviously what's happening to our Prime Minister. We can make our own assumptions about that. And there's also a range of symptoms, particularly neurological symptoms, that seem to be indicated in people who have suffered with severe COVID infections. And that will no doubt be explored more over time. Some occupational groups, including key workers, are at increased risk. But certainly I spoke this morning to someone about social care settings, and we know that care homes, there's a lot of stuff been going on there. It's difficult. And obviously those who had mental health problems or who are at risk of them before are also at increased risk. In terms of the long-term effects in healthcare workers, there have, of course, been SARS and MERS and avian flu. So there have been outbreaks of serious infections in the past. And when you look at the data from those studies that have looked at healthcare workers afterwards, we find actually quite high rates of different sorts of mental health conditions. You can see some examples there about the sort of rates of post-traumatic stress disorder or depressive symptoms. But I think probably the two most influential predictors of final outcome are actually still at the preprint stage. Not sure if you're aware at the moment, but what's happening in academia is that when you produce a paper, because it takes often a bit of time to get into press, people are submitting them to preprint servers. And this is allowing people to see what might be coming out soon. So these two papers, both by Allen et al. And Harvey et al., are not yet peer-reviewed and in the press, but they both predict about a 12% rate of PTSD in healthcare workers looking at previous pandemics. And since they both say the same thing, which is pretty unusual with academics, I think that's probably a reasonable assumption to be likely correct. One published paper that has come out in the British Medical Journal just last month by Kisley et al. Basically looked again at the impact of working in pandemics on mental health. Now, they weren't able to give us a figure for actually what the rate of mental ill health was, but they were able to look at what's called odds ratios, so the chances of people having mental health problems if you've been exposed to working on the pandemic or compared to those who haven't. And what you find is it's nearly twice, it's 1.7 times more likely to have symptoms of PTSD and psychological distress. And I think what's useful in terms of thinking about what to do about it is to look at these risk and protective factors. So we know that younger, more junior people who often were doing work that was way out of their normal comfort zone are more at risk. So as an example there on the Nightingale, I remember speaking to a lady there who was working in the intensive care wards, and she normally worked as a pediatric audiologist. So she did children's hearing, but there she was next to a bed with someone who was unconscious looking after a ventilator. Clearly, a very different experience. Parents, dependent children, those who have been in quarantine, those who didn't get the right support. And also there's this issue of stigma. And I don't know if you've seen, but there have been cases, sad cases of people who are healthcare workers being stigmatized by the general population, presumably fearing that they may be at risk of catching something from them. Lots of protective factors there, which we will cover in a little bit as we go through this talk. But unsurprisingly, if you look after people well, communicate with them, don't give them too long shifts, and good support, that makes a positive difference as well. One particular issue that's come up time and time again in the media is that of personal protective equipment. And this is a study from China, which basically, when they looked at staff's mental health needs, many staff who said actually the main thing wasn't about lack of support or lack of psychology, it was I didn't have the right amount of protective equipment. And that's not surprising. Very much in a Maslow's hierarchy of needs, you've got to look after the basic stuff before you start to get on to talk about the sort of self-actualization and proper psychological support. Now, we were able to look at this issue a little bit by using data that we hold at King's College London, where I work. And we had data on military personnel who had deployed over the last 10 years. And we gathered the data whilst troops are deployed. One of the questions we'd always asked in these samples was, did you feel you had the right equipment to do your job? They've never really used that data before because it wasn't of interest. But suddenly realizing that the PPE issue was so important, we were able to go back and look at that data. So this is of military personnel. And we found that in people who, when deployed, didn't think they had the right equipment, you can see there they were between sort of 1.5 and 3 times more likely to have mental health problems. So whatever the story, the reality of the story is with PPE, what this says is that if people are complaining about PPE a lot, it could be an indicator that actually they may have a mental health difficulty that needs treating. And I think that's an important lesson, really. So the question is, with that kind of background, given that it's an important, the mental health consequences of COVID are important for the general population and are really important for key workers such as healthcare workers, what is it that we should be aiming to do to support people properly? And so what we're going to do is to cover sort of how do you prepare people, and I'm going to cover that bit, and then how do you sustain people whilst they're doing these tasks, and then what do you do in terms of aiding recovery, which hopefully is somewhere in the zone that we are at the moment. So just to say that in terms of a general population sense, what we know here is that actually the most important thing that the government can do at the moment is to try and ensure financial safety of the population. As I mentioned earlier on, it's really clear evidence that economic downturns lead to increased rates of mental ill health and sadly increased rates of suicide. If you happen to be an employer, then absolutely there's a need for proper support, and that includes healthcare workers, which we'll come to in a minute. There's a number of high-risk groups out there, and we've spoken about BAME staff, people with previous mental health problems. And what the advice seems to be there is that rather than waiting for people to come in and seek help, is that the NHS is advised to be proactive. And I know that might seem difficult at times, and actually reach out to people who might be at higher risk in order to try and make sure that actually you can stop them getting into crisis and needing intense support. And you can see just at the bottom here, this also comes from that Centre for Mental Health paper, which came out last month. If there are multiple waves of COVID, then the predictions are that actually the mental health need won't just go up a bit, it will go up in one of those, classic now exponential type curves with each of the waves that come on. Although once again, I just urge you to be cautious about that because that's prediction rather than actually what we know. So in terms of preparing healthcare staff to do challenging tasks, such as the one that many of them have done and are still doing, the first thing that we thought about in terms of the Nightingale is someone ready to do this job? And I'll come on a little bit more to that in a second. But what we really thought here is that people really needed to do a bit of self-reflection, because actually there was a great sort of outpouring of desire to help early on during the pandemic, as you'll probably be aware. Many people wanting to come back to practice, wanting to sort of go from doing an outpatient's job to go and help out on intensive care wards. And the question was is that really the right thing for you to do? So what we did is we asked people to reflect on a number of questions before they made the decision to come on and work in an intensive care unit. So we asked them, for instance, to think about, are they living with someone who's shielding? Because if you're potentially bringing that infection home each night, what's that going to do to your mental health, particularly if the person you're living with, is vulnerable or and they do actually become unwell? What impact will that have on you? Have you had mental health difficulties just recently yourself? Are you in a good psychological place to do this work? Have you got lots of other stressors going on in your life? Have you got problems at home? Is there sick children around? Have you got to care for others? Or have you been involved in trauma in the past that might mean that when you went to an intensive care unit, you might find that very difficult? And if any of those things were, yes, actually I'm a bit concerned, we weren't saying you're excluded. We were just saying you should talk about this to people you trust, maybe even with a healthcare professional if you want, before saying, yes, this is the right role for me. Next thing is we thought that actually people should have frank preparatory briefings. So we know at the beginning of the pandemic, there was a concern, and some of it came to be true, that actually we might not have the right equipment. We might have to make these really challenging decisions between, does someone go on a ventilator or are they too frail or too infirm, and we won't give it to them because there's someone else coming in who might need it. And the first time that you come to make these sort of decisions shouldn't be when you're at the bedside with the patient in front of you. You should have talked about these sort of things before. So people at the Nightingale, certainly, we try to encourage them to have a frank briefing, which was not sugar coated. So, and we were aiming, it never quite ended up, we didn't quite get there to have an anaesthetist make a sort of 3 to 5 minute video of saying, this is what it's really like on an ITU ward. You know, people are going to die no matter what you do, despite your best efforts, and you're going to help, but you're not here to save everybody, because that's just not possible. And we've really thought that was important in terms of setting out what is likely to happen in the future and people's expectations. The next thing was a concept which is called psychological PPE, which is just a snazzy name for really sort of wrapping up how do you properly think about what's going to keep you well when you're going through tough times. So many of you might have heard of something called a wellness recovery action plan, which is basically a way of thinking about the things that keep you psychologically safe before you need them. So that might be, who would you speak to? It might be, you know, what sort of exercise would you do? What music would you listen to? What film would you watch? You know, what foods might you eat? Which hopefully doesn't always involve chocolate and wine, although it's not bad for many people. But to try and get that plan in place before you need it, so that at the point you become distressed, rather than thinking, oh, what do I do? You can turn to that plan that's written down and say, okay, well, let's just try number one and let's see how that goes today. So that's a way of trying to get people to think about things beforehand. Actually, when you look at the evidence for those sort of psychoeducational type briefings of saying you might get some symptoms, the evidence is pretty weak, actually. When we looked at that in military personnel, we find it helps a little bit with the job, but it doesn't seem to help much in terms of preventing long-term mental illness. What the most important thing that perhaps could be done is what's called role-specific training, which is actually, if you are a pediatric audiologist, okay, you're not going to become an intensive care specialist in 2 weeks, but the more training you can get to help you do your actual job, the more likely it is that actually you will feel psychologically safe when you're doing it. Evidence we've got from military personnel shows that actually troops who, when they deploy, are given a role that they felt was outside their normal experience, are probably 2 to 3 times more likely to develop mental health difficulties. So actually training you to do your job well, clearly good for you to save lives, but it's also good for your psychological health. Now, what you've seen there is I haven't mentioned screening. What we're not suggesting is that you should give people questionnaires or sit them down with a healthcare professional to determine whether they were fit enough to do the job. Now, it's worth saying that many organizations do use this. They use scales such as the MMPI, the Minnesota Multiphasic Personality Inventory, which, as you probably know, has got over 300 questions. It has lie detection tests in it, or scales. And the evidence is that these are pretty poor, and I'll come to that in a second. Now, what's called the grandmother test is good. Now, if you haven't heard of the grandmother test, what that says is if you've got someone who's wanting to go into an ITU ward, having previously been an outpatient nurse, they've got problems at home, they don't deal well with trauma, they don't get on with the team they're going to go to, and they're only doing it because they think they're going to get paid more money, your grandmother could tell you that that person's going to have problems. You don't need a formal psychological test to do that. The problem is your grandmother will also tell you that going out in the winter without a coat on will cause you to have a cold, which, as you probably know, is not true. Now, I'm not sure if you recognise this bloke. This is General Marshall. He was Chief of the Staff of the US Army at the end of the Second World War. And without knowing it, he did an amazing study into psychological screening. So in 1939, if you wanted to join the US Army, you had to see a psychiatrist or psychologist who determined whether you were made of true grit, or you had the right stuff, or some cheesy phrase. And if you weren't tough enough, you weren't allowed to join. By 1943, they ran out of people. And so General Marshall overturned this policy and everyone was allowed to rejoin. And they then had to go through D-Day, through victory in the Pacific, and victory in Europe. There was plenty of traumas. And what they found is that for every 5 people screened as being weak, 4 of them went on and had a perfectly good war. So they were wrong 80% of the time, which is a bit of a crap screening program. We repeated the Marshall study, not that it was really called that, looking at troops who went to Iraq in 2003, British troops. We'd gathered data on about 3,000 troops in 2002. And so in 2003, when they deployed, we looked back to that data and said, could we predict who was going to have problems? And then we followed them up afterwards. And what we found using good tests with reasonable cutoffs is that we were wrong 80% of the time. So it's a very nice idea, but actually screening people for psychological vulnerability is both discriminatory because you exclude people who are perfectly okay, and also reduces the number of people who could do your job, and it doesn't work. And just last month, it says February, but it came out in print last month, was a really good study from colleagues that we have in Australia who looked at the use of the MMPI screening tool and some interviews in police recruits. And what they did is follow these police recruits up for 7 years after they had the tests and found they were completely and utterly unpredictable and didn't give any indication as to which police officers went on and had problems later on. So overall, although the idea of screening people to see whether you're tough enough is a nice idea, there's no evidence it works, it's discriminatory, and actually it gives you lots and lots of false information. So that's my bit. So over to you, Derek.
Okay. Thank you for that, Neil. I'm presuming you can hear me now.
I can, yes.
Okay. So I'm going to talk through more detail of what we did with the Nightingale team. And that's our Nightingale team on the left. You can see us there. I don't know if it comes across. Neil's quite small. He's sitting on my lap there. He's tiny. And on the right is the Nightingale itself. And I suppose when we were talking about doing this talk for the PICU group, the obvious question is, how does this relate to PICUs? And I would push that back to you. I suppose we're going to talk through what we actually did in the Nightingale. And that's my question for you. How can you relate it to the work you're doing? So we'll have some questions at the end. So with each of my slides, that would be what I would ask you. How could you do it? So the Nightingale was unique in several ways. One is it was done from scratch. So you can see on the right of the image that that's the unit being built. So it's the XL Centre in London. It's 1 kilometre long. We had 82 wards, each ward had 41 beds. We could design it from the beginning, and we were in there from the beginning. And the second thing, which was a luxury, was that we had somewhat limitless resources. That's not quite true, but we could really, we got lots of scope to do the things we wanted to do. And in my day job in Southeast London, I'm a clinical director as well as a psychiatrist, and I certainly don't have limitless funds. So that's the challenge. We're going to tell you how we applied the evidence to a very specific environment, but then the question we'll come back to at the end is, what would you do with that? So have the next slide, please. Neil's doing my IT, so I shouldn't really have teased him earlier on. And the first thing was about buddying up. So the idea here is, it was quite simple. It was getting people paired up at the beginning of a shift. So you would have 2 people who would look after each other, named people looking after each other, as well as the ordinary organizational command that one would expect within an organization. And this worked to a degree. There's a question at the bottom. I don't know if you've seen it there. I had it thought through. There was one professional group didn't do this as well as any others. I'm not sure what your thoughts are. I know you can't speak out. I'm guessing everyone will get this right. The one group are doctors. So this was an interesting challenge at the Nightingale. There's a thing called medical exceptionalism. I think doctors tend not to believe that the rules apply to them, perhaps. And it's not to say that the doctors didn't buddy up either, but it was perhaps a group. There's an interesting thing about if you're getting staff to pair up, and of course the question to you is, would you want to do that, or how would you do that in your organization? What do you do with different groups of people from different professional and different experiential groups? Next slide, please. The second thing that was implemented at Nightingale was the concept of having what we were called psychologically savvy conversations and post-shift reviews. And again, this might be something that is perhaps more intuitive to you in mental health, if we're having handovers and we're talking to each other. But rather than just talking about the operational part, about saying, well, how many people did we see? What is it we were doing? The principle here is being able to talk about the emotional component of what's happening and being able to see how this is impacting people. Our mental health team, which we'll come on to in a few minutes, fed into this. So they would drop into the post-shift reviews. And the idea was trying to tap in if there are people maybe not fully engaged with it, people who seemed more distressed, or even people maybe less distressed, people not in the moment. And this idea of what's called presenteeism, where people are turning up, but they're actually not really engaged. And now this brings up an obvious, interesting challenge for us. So the principle seems sensible. We're trying to tap in at crucial moments to see how people and the team are doing. But then if you think of your everyday work, we're always busy all of the time. So how are you going to do it? How do you build it into an existing busy schedule? Will people engage? And what do we do about people who decide to say, well, look, not today, I'm dropping out, which isn't necessarily a problem. Next slide, please. We were very lucky with a particular group of people in the Nightingale. We had a lot of furloughed staff who volunteered to give their time to us. And one group of staff who worked with us in the mental health team were furloughed airline workers. And you can see some of them there on the left. They were absolutely amazing. If you want a group of people who are very good with handling other people, it's airline staff. They've seen it all. If you've been on an airplane before, they're really great with it. And these were people who gave their time for free to be with us. And I don't know if it's coming through sufficiently clearly on your slides, but if you can see that they have pink lanyards. And this was a way for them to self-identify to other people. So they literally walked the floor. So they're not clinically trained staff, but they're staff who are self-identifying, saying, we're here to help you. If you want to have a chat. So they would walk up and down, they would drop into the ends of shifts. They had specific places where you could meet during the day. We had little coffee areas and they would sit down there. So again, there's something there where I suppose the obvious challenge is, well, we don't have airline staff working in my units. But this is something that can be done in different ways. And Neil may talk later on about the TRIM model, which he and colleagues have done in the military, about peer support. So it doesn't have to be furloughed airline staff. And I think that might be something, again, maybe in the Q&A session you could think about. The chief executive of my organization in my NHS trust was the deputy chief executive for the Nightingale. And he was incredibly struck by these welfare workers, and also by the principle that maybe there are wider groups of people we can tap into within mental health care. So it's potentially an opportunity we're looking at. And again, off the top of my head, it will vary from where you are. We're already beginning to explore more detailed things like lived experience practitioners and lived experience networks and so forth, non-clinical staff, people who are volunteering to services, having people in non-traditional roles beginning to help out. Next slide, please. The mental health team worked on the PIESI principle, and again, this goes back to work that Neil and others have done in different circumstances. And you can see the acronym there on the left, and it's exactly what one might imagine for this type of service. So the mental health team, the Nightingale, which we were part, our job was to be there, to be ready to get in fast and quick. We weren't going to have complex systems of referrals or bureaucracy that was going to delay people coming up to us. In fact, we weren't even going to just sit in the office. We were going to get out. So you can see their proximity. We were on the same location. And this is where you might begin to challenge about what might you do in your organization. The immediacy that we would be out walking the floor and able to see people really, really quickly. The expectancy and simplicity were the things I really enjoyed, I think, most about my work in that mental health team. A real positive attitude that people were doing a great job in difficult circumstances, and we were non-medicalizing it. Our expectancy was that people would do okay. Maybe they needed a chat, maybe they needed to have a bit of a moan or complain, or maybe to say how they felt it was a difficult day. And most folk, when they do that, are often quite happy to go back to work. There's a real simplicity. It wasn't trying to throw ICD-10 at people. And you can see at the bottom this idea that post-traumatic growth is to be expected in the but although it's difficult, and I think this is something that we might extrapolate to our own work. We're going through, we always struggle to not use the word unprecedented, but we're going through an incredible time, and yet the expectancy for most of us is that we will grow and develop from it, even if it's not something we would wish to be in. Next slide, please. So there's the team there. I've done the empty office on the right to show the immediacy. They're out of the office, they're walking the floor, and on the left we have Mark and Andy. So we got psychiatric nurse and we've got psychiatrist, and their job is to go out and about and walk that floor. And there's one of the things to think about. We're thinking about translating some of this. So that's the evidence base that the PIESI model works for supporting the psychological well-being of staff. And so what we can see in the Nightingale, in our designing from scratch with unlimited resources, we can put this in. So the challenge to us in mental health and our teams and your team is, how might you get that model? So you can't get myself and Neil and Mark and Andy to come just visit your team. We have that disadvantage compared to the Nightingale, and yet we have advantages. One of the things that really struck me in the Nightingale is that in mental health, we're so used to reflective practice and being able to name and talk about complex emotions. And for lots of healthcare staff outside of mental health, that was quite a novel experience for them. So just to be able to say, I've had a really bad day and I'm not sure, I don't like my manager so much. The types of things we might talk about more easily. So I think we also do have some advantages in mental health that perhaps they didn't have there. Next slide. And so this comes on to the next phase, the recovery. And in a way, we only partly got to do some of the recovery at the Nightingale. You'll be aware that thankfully, it was never needed in the way that was first envisaged. So it ended early. But we had a partial step down process at the Nightingale, and that's the O2 Arena in London. So again, this is to, I suppose, demonstrate where the Nightingale is different. So people will say, well, you guys hired out the O2 for your recovery, which was done. So there's a huge arena there where we were beginning to talk through staff about what had happened and what we'd gone through. But we'll go through the detail by going to the next slide. It was the principle of saying thank you to people and of giving them some information. And again, these are some specifics from the Nightingale that I'm not suggesting you do locally, but it's the principle of the thoughtfulness. So you can see up there that everyone got a Nightingale t-shirt that people are incredibly proud of. And I'm not saying everyone needs an NHS t-shirt. Mark Tarn, the clinical lead, has designed some cufflinks for his team. I think Neil, and he's still got yours, he's waiting to give them to you. So that was something for us as a group of people. And the information that was provided to people on finishing in the Nightingale. So we had this day at the O2 where people came together, we talked about our experiences. I'll come on to that again in a minute. And it was giving information and advice about what would you do next. A worry we had in the Nightingale, which you won't have to have, was that our staff were going off to the four winds afterwards. What would we do if people went back to their day job in a different part of the country or the city and they didn't feel happy to talk about it? So we were trying to provide information for them. And of course, there's lots of information in different ways. You can see on the right-hand side of the screen, for example, the Royal College is providing information for people too. And next slide. And the principle of it, and this is where I'll probably begin to move more into my own work in Southeast London, Oxley, is about the phase we're at now, which I'm guessing is where lots of you listening are at too. This principle of a new part of the COVID response, that it's not back to normal, but we're beginning to move out of that acute phase into trying to work in this new environment. And people's work, a lot of our staff in mental health, so not the Nightingale now, were temporarily seconded to new parts or new teams, and now we're beginning to pull them back. And it's trying to do that in a graded, sensible manner and trying to monitor staff as we do that. So you can see some of the issues on screen, and some of it, of course, is nationally driven. So we're all under criteria for quarantining, shielding, and so forth, and these can change on a regular basis. Some of them are locally driven, and one of my questions to you, if you're joining this, is do you know what your trust policy is? How does your team implement that? What are you doing? So I work ordinarily, when I'm not doing my management bit, I'm in a home treatment team. And how do we adapt my local trust policy into my specific team? Because my team works quite differently to an inpatient ward. The inpatient ward works differently to the PICU, and they all work differently to the CMHT. And how do we begin to stratify that for different staff within our team? So Neil mentioned earlier on a few occasions about the AME staff and other groups that might have additional vulnerabilities. Next slide, please. There's an example. I'm certainly not recommending Oxley's where I work as optimal and how to do business, although I like where I work in case anyone from Oxley's is watching, and I think we do a good job. But here is just an example, I suppose. This is just some screenshots from some of the Oxley's documents that we are circulating to our teams, beginning to think about as we move forward, how as a trust are we going to look after our staff in terms of their well-being? How are we going to get individuals to talk to us? So that you can see the types of information. And my hope is you've got a variation on this. And if you don't, my question is it that you don't know about it, or is it that it doesn't exist? And in either case, I think there's a conversation that needs to happen after this. Next slide, please. And this comes on to something which it was both at the Nightingale and also in the work that I do with my trust now. It's about that principle of having a non-medicalized, back to work, positive post-traumatic growth approach, which I think is absolutely key and the right thing to do. And at the same time, recognizing, we think back to Neil's earlier slides, that a cohort of people are struggling now and are going to struggle into the future. I was at a different webinar this morning within my NHS organization, and my chief executive, who I mentioned earlier on, I know he'll be happy for me to say this, he said that it's actually been in the weeks of since having left the Nightingale, it's coming back to him more as he processes it and thinks it through. And he's doing great with it, but it reminds us that these things can take some time. And some people are going to need additional care and additional supports. to me, the evidence base for most mental health problems is fairly standardized. We're aware of it. Of course, people vary, so we can give a stepped approach. Not everyone responds in the same way, but we know what we need to do if someone's suffering with anxiety, if someone's suffering with depression, someone's drinking too much, someone's showing signs of PTSD. The challenge that tends to occur in healthcare is access to services. And of course, we make really bad patients. Worst people are often in healthcare. We're used to helping others, and sometimes we're not so good at looking after ourselves, which is one of the things we're trying to think through now. And the question is, so in the Nightingale, we had very simple, it was the PIESI model. It was very quick. You could see anyone you needed to see that day. We couldn't really instigate care, but we could access it very fast. And so the question for us all going forward is, what is the local process? There must be one where you are. Through line management, although we recognize that sometimes line management is your problem. And how do you jump that if you need to? Through primary care, occupational care, external agencies. Are you aware of the national office on COVID-19? So as well as local, there are national supports for people. And how do you ensure that within your team and within your organization, that people know that? And one of my problems, my eternal bugbear in the NHS, in general terms, is information is often out of date. Even on websites, we look at the numbers that don't work anymore, web links. Is the information there? Is it up to date? And people know how to access it. Next slide, please. I don't know how many people joining the conversation are managers or leaders, but in a sense, we all have this role. If we think back to the buddying system, in a sense, we all need to be looking after each other. How well do we know the people around us? How well do we know our staff? How well do we know their backgrounds and risk factors? And if we think of our own lives, we often go into work where we're smiling, trying to do the job, and it's a tough day for lots of reasons. Maybe there's difficulty in our personal life, our family, our children, our friends, and we try to carry on. So as well as risk factors that we've talked about, maybe some of the epidemiological ones, so people's age or their ethnic background or their weight or heart factors. What are the challenges your staff are facing? Some people will have lost family members during COVID-19 or have family members that are really sick or be incredibly worried or going through a divorce. How well do you know your staff? And what I'm reminded about with COVID-19, the unique challenges for me, one is people tend not to have the access from their loved ones around them. It's often through this type of thing. We're doing Zoom and Skype and so forth. And then the things to which we might ordinarily turn as a source of support are not necessarily there. So whether it's dropping out to have a glass of wine with friends or going for a meal or going to have a football match, our resilience is tested by the resources we may or may not have. And if it's not your role, then whose role is it within your team? Next slide, please. And there's something about making reflection and making meaning. This is the O2 again. That's me. It looks completely empty. I can assure you there were some people at that. That's the entire arena. The people there are facing it. There are a couple of hundred people. And what we did at the end in the Nightingale was to talk through for us the complexity of the emotions that we had had. And for us, Neil mentioned some of it earlier on, from the enthusiasm of having stepped forth and for many of us, the sadness of stepping down versus a guilt at why am I feeling sad about something that wasn't needed. And so emotion can be quite complex for us. Where I think we have a strength in mental health is we're much more used to naming that and saying it. And what I found interesting with staff at the Nightingale, who are primarily non-mental health, they were less used to being able to say that, to say I feel sad and happy. And there's a suggestion on the bottom, some of you may use Schwartz-Brown's as one model where it's not just the operational factors of what we're doing today and who we're seeing, but it's talking about the emotional and social aspects and bringing in a wider community that can involve administrative and non-clinical staff. Next slide, it's just a couple from me left, and then we'll go on to questions. To tie up, in a sense, what we've said, I think, across both of our slides, is this real principle of not medicalizing and nipping things in the bud. And team support and looking after each other and being able to have those psychologically savvy conversations. So what's interesting to me, looking at the headlines in that, to take the Nightingale model, the obvious throwback is my team doesn't have all those things you have in the Nightingale. Well, what we do have is we have lots of these things here. We generally have a principle about non-medicalizing where we can avoid it, about being psychologically informed. These here are our strengths, so how do we take them into our practice? So if I go on to what I think is my final slide for the questions. And at the bottom, which is a paper that myself and Neil and some colleagues have also put out on COVID-19 and prisons. And I appreciate PICUs are not the same as prisons, but I wonder if some of the principles from that you might feel they better relate than from my experience as a home treatment team consultant or my experiences within the Nightingale. The Nightingale is clearly unique, and we applied the evidence base to a clean slate. But I think there's lots there that's common. So the humanity of people doing their work in a difficult situation is common to all of us. And I think there are also longer term opportunities from this about not just how do we help our staff psychological well-being now. So that is the question of the seminar. What do we do now? What do we do in the coming months? But what do we do going forward? What do we do in the coming year or two? What was striking for me too with the Nightingale, a lot of our non-mental health colleagues were impressed by the model that we had and wanted to take that back to their services for longer term work about how we look after ourselves. So in a sense, COVID-19 is an extreme and really important example of the pressures we face, but we always face pressures. So the long-term question is, how do you take that forward indefinitely? And so that's my bit finished. So I think it's back to myself and Neil for questions.
Thank you very much. That was really interesting. So we've got a couple of questions that have come through so far. So I'll just go ahead and ask them. So one person's asked, are we expecting a spike in suicides in the UK in the coming months in specific groups and in the general population?
I'll just start off on that. So I think in terms of the general population, what we know absolutely from previous research looking at economic downturns is that there's an increased rate in mental ill health, particularly depression, and associated with that is an increase in suicide rates. So I think all of us are predicting that somehow all that money that's been spent won't come off the magic money tree, and the chances are there will be a financial downturn. And as a result, yes, we are expecting there to be problems. And the difficulty, I think, from mental health care workers is actually the solutions for those sort of mental health problems will not be mostly in our hands. You know, it's very hard to tell someone who's lost their job and doesn't seem to be able to get another one that actually, you know, that they should be a bit more active. So I think from a government and public health point of view, and there definitely is an awful lot of work going on through DHSC and Department of Health and Social Care and Public Health England to try and both monitor what the general population mental health is and also to try and intervene. But the short answer is yes, we are expecting there to be an increase in mental ill health. I think something that we haven't perhaps touched on, or Derek touched on perhaps a little bit, is we're also expecting that actually a number of people are going to grow as a result of this. You know, you may well have heard of the term of post-traumatic growth, you know, which is summed up as anything it doesn't kill you makes you stronger. And I think actually many people, including healthcare workers, will actually come out of this saying, do you know what, if I can cope with that, the fact that they've run out of 2 for 1 at Asda, you know, is probably not the worst thing in the world. So the Daily Mail narratives of doom and gloom on the horizon, I think is probably not going to be the result of COVID and what happened directly, but it's about the effects on particularly on finances that are likely to have the problems in the longer term.
And I think if I can add to that, I think that's true that it's going to be largely social issues that we will have to see how this plays out. But I think in terms of clinical practice, that the things that teams are trying to do is understand how their work is impacted and how they can best mitigate. But we can, on the one hand, we can recognize that this is likely to come, and we don't wish to be fatalistic. So what do we do to try and mitigate it? And so for me, and I appreciate I'm community-based, and perhaps most of you are going to be inpatient, but it was recognizing that we're not seeing people as often as we ordinarily would. And we're not seeing them in the same way that we ordinarily would. So my team are often doing face-to-face. And like this webinar, I don't know that things are ever the same as doing a face-to-face. So perhaps less often in a different way, and then people have fewer supports around them. We can't change all of those things, but what we can do, I think, as a service is we can be mindful to it. So you might, again, maybe it's, I'm guessing it's going to be different in PICUs, where maybe an issue is about family not being able to visit, family trying to call in and Skype. So with the limitations you have and anticipating the challenges and the risks it puts on people, how does your service try and do the best despite that?
Thank you. We've got another question here that says, what is the reason for excess mortality from COVID-19 in BAME healthcare staff? And I'd like to sort of add to that question and say, how can you best support staff's worries within the BME community, and how can you support them when they might not want to come to work?
So certainly from my point of view, I'm not sure of the answer as to why. I mean, I think I know the science as best as probably anyone does, and I've read lots of the articles, and you've seen the recent report about this. But there does appear to be an independent factor that isn't related to social deprivation and isn't related to other health risk factors like obesity or smoking. That is down to something to do with probably genetics. But that's not my area of expertise. I suspect I'll let Derek answer it. I suspect it's probably not Derek's either. But I think what is pretty clear is that certainly by doing a lot of work with NHS England at the moment, and there now is a risk assessment which discriminates between people who aren't BAME and people who are, and actually puts the age limits for higher risk lower for people who are BAME staff. I think that's really important, but it's also a bit of a challenge. We know people who are who feel that they're in a minority group and that they don't have things aren't very fair for them. To treat them differently in some cases is exactly right, but in other cases it can also make the problem worse. And I think where this comes down to, in my view, is managers should actually be speaking to all staff at higher risk, including BAME staff, but people who might be pregnant, or people who might live with a loved one who might be in a vulnerable group. And actually anyone who's in a higher risk group, I think, should have the right information to make an informed decision about what they want to do. And clearly we can't let people take silly risks, but actually assuming they have capacity, and I think most healthcare workers presumably do have capacity to make decisions, then actually the situation, I think, should rest, in my view, with the individual themselves, as long as they're properly appraised of the risks.
If I can add to that, so yes, it's certainly not my area as to why, and I accept to agree with Neil. I think it's probably a very complex combination of both genetic and sociological factors involved. But I think what we can do within organisations is we need to have the conversations about how do we best support staff, and that's got to be from all of us to have those conversations. And a challenge, if I think about the NHS more generally, is that thing that's sometimes called the white peaks, where senior management in the NHS is classically white males still. It's not as, it doesn't have the representation that we would want within organisations, and we need good leadership from everyone within this. I think there is something to what Neil said about stratifying risk and understanding it. If we think about different services, so community-based services have different risks to inpatient services inherently, and staff are already being exposed in different ways. So one of the challenges we've had to have as a discussion in my organisation is with our inpatient staff, say, why do we allow you to be exposed to higher risk, whereas your colleagues in the community are working from home and talking to people by Zoom? So sometimes you have differences within services, and then within an individual team. I think we need to be able to have those conversations, and people need to feel enabled to put their hand up and say, I don't feel safe with this, and they need to feel secure that they're not going to be judged by that. Now, you want the right form for that. People might not want to do that in a team meeting, but leaders should be able to support staff to do that. And I think Neil is right that there's a balance. On the one hand, one shouldn't presume and say, well, because you're from this ethnic background or you're this age, that you cannot. But I think we must be able to support staff. And in some instances, it may lead to staff wishing to work in a slightly different area or in a different way. And then we recognize that sometimes these things are really, really hard to do. What shouldn't happen is that people feel punished or differentially exposed to risk. The big thing is the conversations. If I think about my organization, we have a specific group looking at that, communicating with the entire trust and trying to have some transparency about this, and also saying, here's what we don't know, but join in the conversation and tell us how we can do it better.
I completely agree, definitely. Okay, so on to the next question. It says, on the lack of protective equipment and high levels of PTSD, I wonder if you could share more thoughts about this within healthcare settings, and why or how a lack of protective equipment raises the risk of PTSD so much.
So what we know about moral injury is that one of the three aspects, which is acts of commission, acts of omission or betrayal by a higher authority, that the last act, which is the betrayal side, very much falls into the PPE. Now, I can't speak for the government, and I'm not sure I would even if I could, but whether my impression is that the PPE issue about the supply it has been largely down to the situation. I don't get the impression that the government have been cost cutting and they wouldn't buy stuff because it costs too much, and so actually, whilst I'm sure many groups of healthcare workers haven't got the right PPE when they needed it, and indeed the same goes in social care settings. You look at care homes; it's, you know, healthcare settings are bad, but care homes have been far worse. Is that the difficulty with it is it begins to create a you and I situation where people feel that they've been let down by someone who should be looking after them. And I suspect actually the people who should be looking after, you know, the procurers of PPE are probably also going to have felt guilt and shame at not being able to do enough to protect the people who they would have wanted to. Now, I know this might sound very silly. So I served in the military for 23 years. And when you have troops in Afghanistan and they're in a situation where you either call in an airstrike to try and save your 10 troops who are in a difficult situation, but if you do that, you may end up inadvertently damaging your own troops or harming some civilians. The question is, what do you do? Now, many civilians would say, well, you shouldn't be in that situation. And that's great to say that. But what happens if you are? You know, people have to make decisions based on the best information they have at the time. And sometimes that in retrospect doesn't appear to be good enough. And I think the COVID-19 situation has put the whole nation, indeed the whole world, into a situation where actually lots of things were not good enough. And what's not helpful psychologically is to end up in a state where you feel let down or you feel that you did the wrong thing. So Derek mentioned the idea of a reflective practice and Schwartz rounds. And I think what that means from a psychological viewpoint is that leaders leading those sort of conversations should be trying to help everyone develop a meaningful narrative that doesn't end up with the blame being laid on, you know, Derek or the boss or the medical director or any one person. That actually, the more you can put it down to, this was a crap situation and, you know, we didn't want to be here, but we were here, and you know what, we didn't always make the right decisions, we did the best we could at the time. Developing that sort of meaningful narrative can help people at least move on. And so I think that's the reason that these they're not having enough equipment and not being given the right training, that they do have the potential to be really psychologically toxic. But that meaningful narrative, however it's developed, is the route towards psychological health.
Great, thank you. And we've got another question here. So what about managers and directors? How do you use the approach to ensure that they are as engaged in their psychological health?
Shall I take that? So I guess there are probably two ways with that. One is, are they looking after themselves? It tends not to be a group that attracts a huge amount of sympathy. Are your managers doing well? But I think it really is important. I'm saying that as a manager and as a clinician. And then probably as important an issue then is are the managers leading these conversations about wellness and well-being? I think managers, there's this danger, I suppose, of trying to be heroic saviors of a service and taking on everyone else's woes and not recognizing that they struggle themselves. And clearly that can't be the case. So there are days I come home and I'm just dog tired, and it's trying to recognize that if you are a manager and you are a leader, you may feel that you have additional you do have additional responsibilities and burdens, and you do have to support the staff working for you, but you also need to look after yourself as well. And I think what's a challenge is making sure you can, that's now the additional role, I suppose, in this time, is having that additional focus. You should always be looking after staff well-being, but now it's more important than ever, as is your own. So I don't know that there's anything different for a manager or a leader in this time, except doing unto themselves as they would do unto others, and being able to have that conversation at different levels. So groups of managers, directors, and so forth, they should be having organizational talks about how are they supporting each other. It's just another team. It's a team at a different level.
Thank you. I've got quite a difficult question for you here. So do you feel that the pandemic...
That's for Derek, that one.
Do you feel a pandemic of this scale, which has ended lives and impacted the entire country in so many ways, physically, mentally, financially, and socially? We've been told repeatedly that the NHS coped with this first wave, yet this was at the expense of services including cancer care and mental health services, which will have its long-term physical and mental health impacts. So do you feel healthcare and the NHS staff should have more of a voice in politics and government? And is it still appropriate for the NHS staff to be politically neutral?
Well, I'll say my point. I'm sure Derek, because I'm not part of the NHS, to be fair. During my many 51 years of being alive and have spent a lot of time in the military and academia, I think I was formally employed by the NHS for about 3 months at one point. The rest of the time that they haven't paid my salary, but although having been part of the military, again, you weren't allowed to get involved in politics. My general view is I don't think it's helpful on a day-to-day basis for organisations like the Ministry of Defence or NHS itself to get involved in politics. I think from an individual point of view, you should follow wherever you want to go. But the fact is, whether we like our leaders or don't like our leaders, we still have to deliver the highest quality care we can. And I think internally we should do all we can to try and get the right resources and get the right policies and all the rest of it. But I don't think going to speak to the media and barrack and sort of standing out with placards saying that the NHS or the Ministry of Defence or whatever organisation you work for has been let down, I don't think that's helpful, because I think that that's something which you should do as an individual if that's what you believe. I'm not sure as an institution. My view is that we shouldn't partake in politics. I don't know, Derek, do you have a view?
Yeah, I would fully agree with that. I think be politically active in your own life in terms of vote. But I think so. I'll give a very quick example, which I won't finish. So I might say Brexit and healthcare. Now, I personally might have very strong opinions on this, but I have to work with lots of people, whatever your opinion on that. So people are going to have different opinions on it. We need to work together. And this is where politics could be quite divisive for me within healthcare. So I think there's a danger about being political at the workplace. My worry is that it divides us internally. I have personal political opinions that are important to me and that I go out and vote with. But I think they can be divisive at this time within the NHS. And I would take it more, which is probably, I think, echoing what Neil said, that it's about bringing together good models of care. It's quality improvement. It's showing political leaders and local political leaders what you could do, working with them. I fear it gets a bit into the barricades, which is not where we want to be. I think it's bringing in local politicians, whether you like it or not. So for me as a clinical director, I need to bring in local politicians and work with them, whether they're my political stripe or not. So I personally think, no, I think it's too dangerous to be divisive, and we don't need to be divided in the NHS. I think your personal political beliefs, that's great, but I think work with people within the NHS.
Thank you.
Just to give you just a little example of that is, and we're not going to give you all the details here, but the mental health team at the Nightingale, to be fair, found some difficulties, to say the least, and Derek will probably smile here, in doing the things we wanted to do because of the NHS processes that we were asked to go through, which mostly we ignored. But at the end of the day, some of the things were just completely ridiculous. And I, not being part of the NHS, not being employed by the NHS, and having plenty of friends at the BBC and all the right, could have probably gone and tried to make a big story out of it. But to what end? That's not the right way to try and solve your problems. And although we might joke about it, the best way to try and solve problems, I think, is by internal dialogue, and sensible debate. That's my view. I think we've got time for one more, maybe.
Yeah, I actually have one of my own questions that I'm going to ask. So it's been previously found that nurses in particular need permission to be able to support their own mental health, or to be able to get supported by other people for their mental health. So do you think everything that's happened with COVID will help this issue, in the sense that they now have a reason to need mental health support? Or do you think that the stigma of all pulling together will have an effect on that?
So it's really interesting. So, sorry to jump in here, but so we again, just talking military. So we did a study about 4 or 5 years ago. I'm not sure if you've heard of it, but there's a big national England study called the Adult Psychiatric Morbidity Study. It's done every 7 years. It was done 2007, done 2014. So one of the things that we thought was that military personnel, a bit like nurses or healthcare workers, they have a stiff upper lip, and so they won't tell anything about their mental health because that's not what we do. And the assumption, therefore, is that everybody else is a lot better, and that it's a particular problem for nurses or for doctors or for military personnel. So we looked at the APMS data in 2007, and we looked at all the people in there who, and it's a really good study done by interview, who have PTSD by interview. And then what we did is took out the veterans, and we were trying to look at, do the veterans seek help more or less commonly? And we thought the veterans won't be seeking help and everyone else would be a lot better. Guess what we found? Everyone was the same. 70% of people, whether you were a veteran or not, weren't seeking any help at all. And so I think absolutely it's a problem for organizations like the NHS and for medical personnel and for military. I always joke that if you're a librarian, maybe you go and get mental health care very quickly. I don't know any librarians. I don't know if that's true. But I suspect that this is a national and probably very much a cultural aspect, is that we feel frightened to get help. What I think has happened, and we've measured this a bit, is over time things are improving. They're getting better. In the military, they're getting a lot better, but there's still over half of people in the UK with mental health problems don't get any help at all. And so what that means is I think COVID will help accelerate that. But I wouldn't try to look too much that any one particular professional group is worse than everyone else, because I think we're all probably as bad as each other, unless you're a librarian. Derek, do you have any?
No, well, I suppose an observation from the Nightingale work was that we saw people, so some of the staff who went in were newly minted nurses and doctors. It was their first job. And Neil mentioned it was from ITU consultants to pediatricians, and some people were 50 years in the NHS. And I saw no pattern. It wasn't that new staff necessarily did worse. Some new staff, they went in and they thrived. And so I think we've got to be careful about any presumptions. And across the Nightingale, there was no pattern between professional group or level of experience.
That's great. Thank you so much. I think we're going to have to round up there because I've just realised it's 1 minute past 2. But thank you both so much for coming to speak to us about that. As I said, it's a real sort of passion topic of mine. And thank you to all the attendees who've listened, and we'll see you soon.
Yeah, and thank you very much from us. And if you want any more information, both Derek and I are quite active on Twitter. If you join us on Twitter, we'll happily send you our papers and stuff that come out if you want to keep up to date.
Lovely. All right, well, thank you both.
Bye-bye.